So our next speaker is Dr. Shama Puri. She is a consultant radiologist here at the University Hospitals of Derby and Burton, following completing her radiology training in Sheffield and then being appointed here in 2005. Her specialist interests are gynecological and breast imaging, and she's a core member of our specialist MDT here. Thank you very much.
Hi, good morning. Can you see my presentation? Yeah, okay. Yeah, so thank you for inviting me to talk on radiology of uterine cancers. So in my talk, I've got two parts. In the first part, I'm going to concentrate on radiology and FIGO staging of endometrial cancer. And in the second part, which is the shorter part, we'll look at if we can differentiate leiomyomas from leiosarcomas. And to help understand this better, I'm going to talk about MRI technique and anatomy as well. So we have different imaging modalities available to assess endometrial cancer. The very first method which we use is transvaginal scan, and I has already touched upon that. When the lady presents with postmenopausal bleeding, that's the first investigation we do. And once the diagnosis is made, then MRI is used for local staging. CT is not good for local staging and is only used for detecting distant metastases, usually in type 2 disease and also in recurrent cancers. And then PET-CT has got a role when the endometrial cancer recurs. We don't use it in primary staging of primary endometrial cancer. So just quickly going through it, this is the screening test which is done on women presenting with postmenopausal bleeding. And here we take cutoff value of 4 millimeters. So anything 4 millimeter or below does not need a biopsy. And this has been shown to have negative predictive value of 99%. And showing how it is taken, the endometrial thickness is measured on sagittal images. You measure from one end to the other. And endometrium can be thickened diffusely, or it can be focally thickened in form of a polyp. And if there is fluid in the endometrial cavity, then that fluid should not be measured, and you measure the two lining of the endometrium on each side and avoid the measurement of fluid to get accurate measurement. Once the biopsy is done and diagnosis is made, then the local staging is done by MRI, as I said earlier. So MRI is really good at identifying the uterine as well as extrauterine spread. And when the MR findings are put together with the histology, it can give us a very accurate risk stratification and help us accurately identify the patients who need lymph node dissection. So MRI will show us depth of myometrial involvement, whether it's superficial or deep, which is taken by 50% criteria. So if 50% of the myometrium is involved, it's called superficial. If more than 50%, it's called deep. It shows us if cervical stroma is involved, if there's any extrauterine spread to the ovaries, to the parametrium, to the bladder or rectum, and also if there are any involved, obviously enlarged lymph nodes. It also gives us an idea about the resectability and if we need to involve any other teams if we deem that the surgery is going to be difficult. In addition to this, MRI can be used for road mapping for abnormal lymph nodes. So we try to tell our surgeons very accurately where these nodes are, so none of them are missed. MRI also gives us a good indication of the uterine bulk and also can be helpful in showing other findings like abdominal wall hernias or deep infiltrative endometriosis. And with all these, you get good idea of what surgical approach will be better for the patient. Could it be open or laparoscopic? In addition to the initial evaluation, we can also use MRI to assess response to treatment. So, for example, in a neoadjuvant treatment in patients who are not operable, And we can also use that to find recurrent disease. Now, why MRI? Why not CT or PET or ultrasound? So MRI has got highest soft tissue resolution. It gives us absolutely excellent detailed anatomy, and the differentiation between the tumor and the normal structures are best done by MRI. It can also give us functional assessment of the tumor by using diffusion imaging. Obviously, it involves no radiation, and it has shown to be accurate. We had this nationwide audit in 2012 where all the UK radiology practices who do MRI for endometrial carcinoma staging were invited to participate and submit their data for 12 months. And then those findings were correlated with the histology, and they found that there was 82% accuracy of MRI for depth of myometrial invasion, 90% for cervical extension, and 94% for pelvic lymph node involvement. So talking about the technique of MRI, ideally, patients should be fasting for 4 hours as it reduces the peristalsis. Images are best obtained if patient lies really still and there is minimum peristalsis. And to facilitate that, not only fasting, we also give an antiperistaltic agent. Usually buscopan is given. If buscopan is contraindicated, glucagon can be given as well. We say partially filled, moderately filled bladder. It's because if the bladder is overfilled, the lady is going to be uncomfortable, not able to lie still. And if it's very underfilled, then that space is taken by the bowel loops, and it tends to give us suboptimal images. Patient lies supine and intravenous contrast is given. So we obtain high resolution T2 weighted images. These are the best images to see the anatomical detail. We acquire them in 3 planes. First, the sagittal plane is taken, and once the endometrium is identified, we take 2 further planes, one parallel and one perpendicular to the endometrium. I'll show you in a minute. We also give contrast and then do post-contrast images, and we now routinely do diffusion-weighted images on all our endometrial cancers also. Now, to give you a little bit of understanding of diffusion-weighted imaging, diffusion-weighted imaging basically assesses how freely the water molecules can move around in a tissue. So if water molecules can move freely, we say there is no restrictions or no diffusion restriction. And if water molecules can't move freely, then we say the diffusion is restricted. So malignancies, which are very cellular, tend to show restricted diffusion, and the benign tumor or benign tissues do not show diffusion restriction. And to assess that, we look at 2 sets of images in 2 sets of images together. The first one is called DW images, and second is ADC map. It sounds complicated, but I'll show you images in a second to make you understand that better. So this is the sagittal image, which is taken first. We find the endometrium and then do further cuts. So this is perpendicular to the endometrial orientation, and we get that. And then the other sequence is parallel to the endometrium, and then we get the coronal image of the uterus. So showing you the anatomy. So just to give you a little bit of idea, this is sagittal image. So we are looking at the uterus sideways, or looking at the woman sideways. This is symphysis pubis, and this is spine. This is sacrum and coccyx. This is uterus in the center. This urinary bladder anteriorly. There is rectum posteriorly. These are some small bowel loops. The bladder and the fat both are bright on T2 weighted images. So all these bright bits you're seeing in between the organs is the pelvic fat. In the uterus, you can see zonal anatomy really beautifully. So you see 3 layers. The innermost is the brightest layer, which is the endometrium itself. And then in the myometrium, you have 2 layers, the outer myometrium and the inner myometrium. So inner myometrium is much darker than the outer, and it's called junctional zone. And this is the outer myometrium, which is less dark. Similarly, cervix has got 3 layers as well. I know we're not doing cervix, but just for understanding, we have mucosa, and then we have fibromuscular stroma with 2 layers. Inner is darker and outer is less dark. We have vagina. We can see 2 walls of the vagina really clearly. They are dark. So that's anterior wall, that's posterior wall. This is bladder and urethra. Again, you can see the urethral wall really clearly, and that's the rectum. Okay, and this is the other view. Again, same thing, you see the endometrium, the junctional zone, and the outer myometrium. This is bladder. So how does the tumor look like? Tumor looks gray. So the endometrium is quite bright. Tumor is slightly brighter than the myometrium, but darker than the endometrium. So that's the tumor. And that's the other picture. So that's the normal endometrial lining, and that's the tumor. So if you note here, the junctional zone is just about seen, and tumor has not gone beyond that. So that's superficial involvement or no involvement. That's the tumor again, same patient. You can see the junction zone is preserved. So that means this is early endometrial cancer. And this is on giving contrast. So the cancer does not enhance as brightly as the myometrium. So you see that quite clearly. And coming to diffusion weighted images, they are quite important to understand because we use them in sarcoma, leiomyoma differentiation as well. So you look at 2 sets of images. This is called DWI images, and this is ADC map. So cancers are bright on DW and dark on ADC. So the anatomic resolution of these images is very low. As you can see, you can hardly see any anatomy. So you have to correlate them with your other images, images where the anatomy is seen, so you know where you're looking. So this is a cancer, bright and then dark on ADC map. No other combination indicates restricted diffusion. So if it was bright, that's not diffusion restriction. If it was dark, it's not. If it was other way around, dark here and bright there, no. So only way of saying that diffusion is restricted when it's bright on DW and dark on ADC. So FIGO staging, we are not using the 2023 yet. We are still using the older one. So 1A, as we said, is less than 50% myometrial invasion. 1B is more than 50%. When cervix gets involved, it's stage 2. And when it goes beyond the uterus, it becomes stage 3. 3A to the serosa or adnexa, and 3B to vagina or parametrium. When nodes start getting involved, we have 3C1 and 3C2, which is pelvic and parayotic node. 4A is invasion into the bladder or bowel mucosa, and 4B is distant metastasis. 2 things to note here is the stroma. So if the cancer is going into the cervical lumen, that's not 2. It has to involve the stroma. And again, in 4A, the mucosa has to be involved. So just wall involvement does not mean 4A. So to show you some examples. I've already shown you 1A example of 1A. This is another one. So that's a little bit of normal endometrium, and then we have the tumor. This is a fibroid. This is the tumor again, and you can see the junctional zone looks all right, and the myometrium is quite uniform all the way through. This is contrast enhanced, and it doesn't look like it's gone any deeper than 50%. In fact, it's pretty much less than that. So that's stage 1A. Stage 1B, this tumor was quite isoechoic to the endometrium and myometrium, so you don't see the tumor very well on T2 weighted images. Again, quite difficult to see, But with contrast enhanced images, we can see that tumor does not enhance, the myometrium enhance, and on the right lateral aspect, it reaches quite close to the serosa. So this is 1B. That's another 1B. That's the tumor. That's the tumor. And you can see it's going quite deep into the myometrium. So that's 2B. So I've shown you examples where it's nice and easy, but in real life, it can be difficult to assess myometrial invasion. And these are the factors which can lead to that. So you can have poor tumor to myometrial contrast. That can usually be sorted by using diffusion weighted and contrast. However, large polypoid tumors can make it quite difficult. When tumors are quite large, they compress the myometrium, they cause thinning of the myometrium, and the depth of invasion assessment becomes quite difficult. That can happen in elderly patients as well, when myometrium can be quite thin. You can get peritumoral inflammation, which can look like tumor, so we can overassess the depth of the invasion. There can be anatomical variation, or there can be things like fibroids and adenomyosis, which can make things difficult. So for example, look at this tumor, very bulky, large tumor, and that's the only myometrium we have. It's very, very thin. Now, assessing 50% or more than 50% is very difficult. So that's the same patient with very thin endometrium, especially here. The endometrium is so thin, it's so difficult to say whether it's involved or not. So when it happens, what we look at is the endometrial, myometrial and endometrial cancer interface. If the interface looks quite smooth, it is more likely to be compressed. But if the interface looks irregular, then it's more likely to be invaded. This patient has got a lot of fibroids. That's the tumor here, and then it goes in here. And again, there are so many fibroids, there's tumors, so it can be quite difficult to say whether this is deep or not deep. So these are the limitations which we face in day-to-day life, talking about myometrial depth invasion. Okay, so moving on to stage 2. This is a cervical stromal invasion. This case is really gross, so large tumor, and look at the cervix. So if I've put this picture to show you the normal cervix is quite dark, but if you look at this cervix, this intermediate signal intensity, so whole of the cervix is grossly involved. This is type 2, stage 2. This is another less gross case. The tumor is quite bulky, but cervix is involved just here. So you can see the posterior fibromuscular stroma is seen quite clearly. The anterior one, half of it is gone. You can see the lower bit. So this is cervical involvement leading to stage 2. Stage 3A is when serosa is involved. Serosa is breached. So large bulky tumor. This is the coronal view, and this is T2 weighted image, and you think it is very close to the serosa, whether it's breached or not, difficult to say. We give contrast, and you can see the serosa quite nicely here, but when you come here, there's a break and looks like the tumor is extending and involving the serosa. So this was 3A. That's another patient. So this is same patient, but taken at 2 different times. She had initial imaging, and it was 1A, 1B disease. But she couldn't have surgery because of some comorbidities and a high anesthetic risk. Surgery was delayed. And when she came back for surgery 3 months later, we repeated the MRI, and you can see the tumor now reaches the serosa, where it didn't at that time. That's 3A. And 3A is adnexal involvement as well. Bulky tumor, you can see this is ovary with solid areas in. This is the axial view. You can see the solid areas more obviously. Now, there could be synchronous ovarian tumors as well, in addition to the endometrial cancer. However, although we can't tell histologically, looking at the rest of the tumor, if it's very bulky disease and it's very extensive, it's more likely that this ovarian involvement is because of the endometrial cancer. That's another case with bilateral ovarian adnexal involvement, bilateral hydrosalpinx as well. Another bulky tumor, and it's going into the myometrium. You can see there's nodular extension, better seen on the coronal images. It's going out. So that's 3B. And when the nodes start getting involved, it's called 3C1. So this is bilateral adnexal involvement or ovarian involvement, but there are nodes here as well. It's obturator and external ileal nodes on the right. And higher up, in another patient, there are paraiotic nodes, so that's 3C2. Now, stage 4A disease is pretty rare in endometrial cancer. Unlike cervical cancer, they don't tend to invade bladder or rectum. I've just put this picture. This is a case of recurrent recurrent endometrial cancer. And so that's the cancer, and there was clear invasion into the rectum, but this is not primary cancer. With primary cancer, 4A disease is quite rare. 4B, distant metastasis. The only minority of endometrial cancers show distant metastasis at presentation. I've put these two cases because they were interesting. They both had distant metastasis from endometrial cancer, which was undiagnosed at that time. This lady, as you can see, she's got bilateral hip replacements. She was having pain on the right side of her pelvis, which she attributed to her right EHR, which was done recently. So there was a little bit of delay in presentation. When she came, she had pelvic X-ray, and there was obvious destruction of the right side of the pelvis. So she had a CT scan. So that's the destruction of the bone with the large soft tissue tumor, which obviously you can't see on the plain film, but on CT you can see there's a soft tissue involved with that. And as you look in the pelvis, there was a large tumor where the uterus should sit. So she had an MRI, and she had a really big cancer, solid cystic necrotic type 2 cancer, and exactly same looking cancer in the bones as well. And that was grossly going into the parametrium. This was another case. She came with generalized symptoms. She had a CT scan, had large ovarian mass, she had ascites, she had a mental disease. It looked like ovarian cancer. But when we looked at the uterus, she had this endometrial mass, which was biopsied, and this was serous endometrial carcinoma. Okay, so in addition to the staging, we can assess response to treatment, and we can also monitor and detect recurrent disease. And showing you some examples. This lady was not suitable for surgery. So this is pre-neoadjuvant chemo. This is post-neoadjuvant chemo. Very large tumor in the cervix, in the fornices, in the vagina. And this is post-neoadjuvant chemo. All looks low T2 signal. The tumor just disappeared magically here. And MRI was very reassuring. This is another lady who had type 2 endometrial cancer. 2 years later, she presented with PV bleed, and we did an MRI, and she had a recurrent cancer. Exenteration was considered for this lady, and when such is the case, we always do a PET scan, because before taking such a large undertaking, you need to know that cancer hasn't spread elsewhere. So these are PET images. That's the uptake in her primary cancer, and there was nothing elsewhere. So that was the only disease she had, and she underwent anterior exenteration. This was another lady. She had this very large recurrence here, which was going into the rectum. I showed the case earlier on as well. There was tethering of bowel to it. But on CT scan, she already had distant metastasis, so no operative action was taken. So to conclude, I would say that MRI is accurate in delineating the disease extent in endometrial cancer. And when we put MRI and histology together, it can optimize and guide the surgical management. When the histology is unfavorable or when the disease is advanced, then CT is recommended to look for distant metastasis. PET-CT is done when there is recurrent disease, especially when the pelvic exenteration is being thought about. Okay, so that was endometrial cancer. Do we do questions here, or shall I finish my talk and then this is the second part of the talk?
Okay, Shama, if you finish your talk and then we'll take questions at the end.
Okay, yeah,
we've got
that's
probably
fine.
a few more minutes. Yep.
Yeah. So can we differentiate leiomyosarcoma from benign leiomyoma? So in this part of the talk, whenever I say sarcoma, I mean leiomyosarcoma. That's the most common type. There are other rare types, which I'm not going to talk about. So there can be confusion between the two. And to give you the background, we are using more and more uterine sparing surgery. We are doing myomectomy. We are doing morcellation more. We are also using image-guided therapies more, such as uterine artery embolization, focused ultrasound, MRI laser. And if we don't get the diagnosis right, if we presume a sarcoma to be a fibroid, it can potentially result in dissemination of malignancy or delay in diagnosis. And on the other hand, if we overcall them, then lady can have more extensive surgery than she actually needed. So we need to try to accurately assess whether something is a fibroid or a leiomyosarcoma. And best thing to do is to use multiparametric MRI. So multiparametric basically means not only doing the T1, T2 weighted images, but giving contrast, giving diffusion weighted. So trying to use all aspects of MRI. Having said that, it can be quite challenging to differentiate between the two because there's a lot of imaging appearances which are overlapping between the benign and the malignant disease. And so far, there is no pathognomonic diagnostic criteria, which when we look at and say, that's it, that's sarcoma. Not yet. So if we look at the two ends of the spectrum, one end is when something is very obviously fibroid on MRI, and that's easy. And the other end is when you've got frankly malignant tumor and there is metastatic spread, there are peritoneal metastases, there's nodes, and then you definitely know this is leiomyosarcoma. However, in between, when those benign leiomyomas start having varied complex appearances, either due to degeneration or due to cellularity, that's when the things get complex. So leiomyoma they have really characteristic appearance. They are round and well circumscribed, as you would expect. This is the most significant feature. They are homogeneous, tend to be homogeneous, and low T2 signal. So low T2 signal is absolutely pathognomonic of a fibroid. Other images are less used. Other features are less useful. And they do not restrict. As we said, it's the malignancy which shows restricted diffusion. However, if there is more cellularity or if there is heterogeneity of the fibroid, they can show restricted diffusion as well. So we'll look at it, how to sort this further. So because it doesn't have restricted diffusion, it is low signal on DW and low signal on ADC. Remember, I showed you two images of diffusion weighted MRI to be looked together. So it's low on T2, low on DW, low on ADC, and somebody has described it as a blackout phenomena. So just, I guess it's helps in remembering. So these are the pictures. This is the fibroid, absolutely low T2 signal, looks very dark. So when I say low T2 signal, that's in comparison to the myometrium, and it's homogeneous, it's round. So there are multiple fibroids here, and on diffusion weighted, they are low. So this is blackout phenomena. However, cellular leiomyomas, they lose their low T2 signal and they now become brighter, or so they become more intermediate signal on T2 weighted images, and that's when the problem happens. And due to high cellularity, they can sometimes demonstrate restricted diffusion as well. And these are the features which we look for in leiomyosarcoma. So that's where the things are getting more complicated. So this is cellular leiomyoma. Looks nothing like these black fibroids there. And leiomyosarcoma can look similar. However, it tends to be more heterogeneous. And look at this. There are so many types of degeneration we can get in fibroids. Myxoid, hyaline, red degeneration, and they can have very varied and complex appearances. This leiomyosarcoma does not look much different from these degenerated fibroids. So what do we do? So leiomyosarcoma have got similar features. They have intermediate T2 signal intensity like cellular fibroids. They have heterogeneous areas of hemorrhage and necrosis that can be seen in fibroids as well. One thing which is different is that they can involve endometrium. So you might get loss of homogeneity or irregularity of the endometrial stripe. If that's the case, then endometrial biopsy should be done. And they restrict, but cellular fibroadenomas can restrict as well. Sorry, fibroids can restrict as well. So in last 4 or 5 years, there has been a lot of publication about MRI use in differentiating benign fibroids from leiomyosarcoma. And these two papers have made quite an impact. This is a very recent one published in Radiology. And what they are saying is that to differentiate between these two things, the main player is diffusion weighted MRI. That's what you have to do. And also they have made the criteria very specific. So it's not just high signal. You have to compare to the endometrium. And if endometrium is not visible to the lymph nodes, and if it's higher than that, only then you say that it's restricted, not just high, it has to be higher than endometrium. And also when we look at the ADC map, they have said that ADC, because in ADC map, you get a number as well, an objective number, it has to be less than 0.9. And by using these, they found that it had quite high sensitivity and specificity, both for experienced and inexperienced readers. Obviously, you can see it's not 100%. They had false positive cases, but that's the best they could do. So they have, in their paper, they give this flow chart to follow. So if you have an uterine mass, and if you think it could be leiomyosarcoma, you first look at any evidence of metastasis. And if you have, then you know it's cancer. And if you haven't, then you look at T2 signal. If it's low, you know it's benign. If it's high, then you do diffusion weighted images and you see whether DW images are bright or not. And if they're not, it's benign. And if it's not bright, then you go to ADC and you measure your ADC. And if it's less than 9, then it's likely benign. And if it's more, then it's suspicious for malignancy. So they tried to make it quite systematic. And similarly, they have given this in picture form as well. So if this is low T2, then you look at your DW, then you look at your ADC. So that's quite helpful. So these are two examples there put. This is a cellular fibroid, and this is leiomyosarcoma. You can see this has got more smooth margins. It has got more irregular margins. It looks more heterogeneous. But they both have high signal on DW images. But when you look at ADC, this is much darker than this one, which means objectively this had ADC value of 0.7 and this had 1.2. So according to them, this is the differentiating factor in showing whether this is fibroid or a leiomyosarcoma. So that's how this goes. So to conclude, I would say that MRI can if I can say that, can correctly identify benign leiomyomas from leiomyosarcomas. Negative predictive value, if you systematically review it, is pretty high, as close to 100%. However, we can overcall cases, so we can call complex fibroids as leiomyosarcoma, so we have to be mindful of that. Thank you very much. That's the end of my talk.
Thank you, Shama. That's a fantastic talk.
I can see a
I
hand
think
already.
in terms of the biggest changes, that measurement that you've measured, just mentioned there, and I think that may be one of the main things in differentiating fibroids from leiomyosarcomas. We'll have one question, and then we'll move on to Jonas. Do you want to, Olivia? Do you want to
Yes.
turn your camera on and ask your question?
Oh, hello. Sorry, my camera doesn't seem to work.
Okay.
It's okay.
Okay. So I need to ask. We had a patient who was diagnosed with. Initially, we thought it was leiomyosarcoma because she had enlarged lymph nodes, and then she had PET CT showed uptake in the tonsils as well. But later on, it was discussed that I think the MRI showed that it's not actually sarcoma. It was just a leiomyoma. So that's where I'm confused. Is there any chance that a benign leukin mass can cause lymph node involvement?
I wouldn't say so. What where were they, and were they related to the tonsillar cancer?
So she was referred to ENT for further investigations, but she had pelvic lymph node involvement.
Was it pelvic lymph nodes?
Yes, pelvic lymph nodes.
I mean, it's difficult to comment without looking at the images. Did they actually look obviously malignant, or were they just borderline enlarged? Because with benign conditions, you won't expect lymph nodes to be enlarged. And if fibroids looked just like fibroids, then they were fibroids. So eventually, what was it? Was it not leiomyosarcoma? Was it leiomyosarcoma?
Yes, it was decided that it was leiomyoma. She was a young girl, 28 years old, and she wanted to have kids and all that. So
I suspect without the images and things,
without the images,
case,
it's quite difficult to comment on these things.